part of this, we have designed this program is to have this concept of a learning layer. So this learning layer is actually a combination of
Mic. Can you mic?
Sure.
Can I just help? Like when the next person is speaking, transfer them.
So, like I was talking about the learning layer is basically comprising of people from the district administration. So the DC is signed an MOU with us, and the DC has also enabled us to work with different district authorities from the education department, health department, police, and various other departments. And then at the same time, we are working very closely with the community. When I say community, it's also ASHA workers, it's also the villagers, the A&Ms. It's the whole plethora of people when I say community. These two people together are facilitated through our team, the secretariat, as well as our fellows, the pair of fellows we have in each of the districts. And obviously, the healthcare providers also play an important part of this. And we are calling this the problem solving unit, the PSUs. And so right now, our working model is that the fellows are coming with their own understanding of public health, social work, but we are adding a layer of design thinking, systems thinking, so that they can identify problems in a very genuine ethnographic sort of way. Uh, Moving on, using this process, okay, yeah. So using this process of design thinking, system thinking, our fellows have identified problem areas across the 4 districts we are working in. The first district is in Chamarajnagar, where we are working on adolescent girl health, and this did not come randomly. We had done consultative meetings with the DC. We had done a lot of focus group discussions with the community, and then we strategically chose adolescent girl health because it is an intergenerational effect. It is not just trying to solve for an outcome, not solving for a symptom, but trying to understand the root cause and then trying to solve for it. So that is why in Chamarajnagar, very progressively, we are looking at adolescent girl health, ensuring that a 360-degree overview is done, that we are prepping them with knowledge through Prana Sakhi program. Our team was very instrumental in designing a curriculum for adolescent girls. And using that same platform, we are also strengthening the health system. From a demand side, we are creating the progressive demand from the adolescent girls to seek health. From the demand side, we are also strengthening the health system to provide appropriate adolescent support whenever they come back. So that is about Chamarajnagar. And in Dubri, it's a totally different geography. I'm sure you're aware of riverine islands like Majuli. So Dubri is one of those riverine islands which keep shifting. And because of the geography, as well as because it's close to the Bangladesh border, there is a lot of neglect in terms of access and all of that. So there is an issue of access. A lot of the women are not able to reach the institutional delivery points on time, and some of the births are also happening during transport itself. So Dubri is another problem area where we are working on maternal child health. In Kuti, we had started with malnutrition, but we also understood VHSND is a very strong platform for us to leverage. And once we build the VHSND platform, we can build on other problems and solutions as well. So we are looking at malnutrition as the starting point, but strengthening VHSND. So that is about our work in Koti. And in West Singhbum, it's because it's predominantly forested area. There is a different type of malaria which actually Dr. Suranjan told us through mal, and there are so many other issues which are interconnected. So we are looking at malaria at a more holistic level, systematic level over there. So these are the 4 problem areas, 4 districts that we are working in. And so when you see these numbers, 330 in each of 330, 130, 120, it might look like small numbers for a researcher, but actually what we have really done is each of these numbers have an in-depth sort of engagement. Each number is, our fellows have gone and done a shadowing. They have followed them across different stages of their work. One, for example, during Asha worker has been followed through a non-VHSND day. What is she doing? During a VHSND, what is she doing? They have followed them from day to night, understood what their challenges are, and then come up with different problem statements. So each of the numbers signifies a much more deeper engagement with the stakeholders to identify problems. Parallelly, we have taken another approach just so that we don't put all our eggs on the fellows who are not fully trained. We have also have this district survey coverage where we are actually we have deployed a agency who was instrumental in doing all these national surveys. That agency has come on board and done a much more thorough survey through Shaivya, who is our M&E person. So she has enabled a much more thorough baseline survey that has happened across these 4 districts. So we have a strong input in terms of qualitative data coming from our fellows and then quantitative plus qualitative data coming from our district survey. So these two together, this two-pronged approach and two-pronged approach helps us get a more holistic idea of what we are solving for in each of the districts. So this is the team. The reason why we are showing off our team is to show that we have a very multidisciplinary sort of approach here. So we have Neha, who comes with a very hardcore background. So I come from a more design background, trying to look at prototype solution. Pallavi and I and Vignesh, we constitute the design team. Neha, I mentioned, is the knowledge management, but she also brings in a research perspective to the organization. Then we have Muskan and Shaivya, who bring in the more data plus monitoring and evaluation approach, making sure that our solutions actually make sense. What are we solving the right problem? And then Ram brings us the health perspective. He brings all of you together as well. So, and Vaibhav is on comms. Utpal makes sure that we are looking at it more hardcore data. He's our lead data scientist. And these are the most important set of people, our fellows on the ground. So they are ensuring that we are collecting the right kind of, are we solving for the right problem? So our fellows are doing that. So now digging deeper into what we are really for now is that in each of the districts we have come up with different problem statements, but we have also simplified this for the sake of the hackathon because we wanted to see which problem statement makes sense for an AI kind of context. There are much more nuanced problem statements, but we have kind of rounded off the edges so that it makes sense for an AI hackathon. Just to take you very quickly through this, the first one is how might we enable a rapid point of care identification of malaria-induced species. This actually came from Dr. Suranjan and his one mentor called Dr. John, who told us that many people normally just solve for malaria caused by mosquitoes in water bodies. And what we also realized in places like Jharkhand, especially in West Singhbhum, these mosquitoes stay on trees and slow-moving water. So we need to identify which kind of malaria mosquito is causing this malaria, then address the parasite accordingly. So that led to this problem statement, the first one. The second one is, this is an overarching across all our districts that awareness, I'm sure you're aware that, that everything comes in either Hindi or in English. But a place like Kooty, they have very local languages there. Right now, it's not coming to my mind. Sorry? Ho and couple of things are there. So, and those languages don't even have scripts. I mean, they have scripts, but they're not usually used for communication. But it's a spoken language. But how do we create health communication using these local languages which the tribals use? And so that is where the how might we statement is coming. The third one is on how do we enable early detection of high-risk pregnancies. I think that is straightforward. It's more coming from our Dubri context because we need to act quickly and make sure the transport is available. Is the health facility prepared for addressing such complications? So the HRPs are coming from there. Finally, this is again coming from Dubri. How do we make sure that once they have identified HRPs, maybe properly, like devices like Doto, so how do we make a referral based on that? So that is about this. And finally, this is coming from mostly from our Koti experience where the district collector, as well as in Chamaranagar, the district collector would want to know data on a readily available sort of dashboard or decision-making tool. How can we present it to her or him to make decisions quickly based on maternal child health data? So these are the 5 statements that we are presenting to the larger audience. And we invite not just the 5 participants who have got selected, but even the people who are just attending here, if they can come talk to us, anyone from the team, and then connect with us, we would love to have this conversation and see how we can work with you in our respective districts. So this is just the start of the conversation. We have packaged this as a hackathon, but it's more to just start a dialogue with each and everyone who is over here. So with that, I would give it to Shaivya, who will introduce the guests. Yeah. But come here, come here. Thank you.
Thank you. Thank you, Karthikeyan. Among us, we have five jury members actually.
Closer.
Okay. So we have five jury members. One is not present.
Oh, Kodukku ma'am.
So I'll start with Dr. Anuya. So he has worked in progressive leadership roles in health technology to achieve impact at scale over the past 2 he is presently at Jaipur and is focused on designing and implementing digital health innovations. He has a special interest in responsible artificial intelligence, digital healthcare workflows, and recently resulted administrative progress for healthcare workers. The second jury member that we have among us is Dr. Suranjeev, who is a Senior Director of Strategy, Growth and Partnerships at Jepaigo, India. He has significantly contributed to developing Jepaigo's initiatives such as nutrition, women's cancer, tuberculosis, and immunization across India. In 2006, the Packard Foundation awarded him the Leadership Development Mechanism Fellowship for Sexual and Reproductive Health. The third jury member among us is Dr. Vivek. He is the lead national professional in the health team at UNICEF India. Vivek has over 20 years of global experience working with the state, academia, and United UN agencies. He also holds adjunct faculty appointment at Emory University. So he is also a recipient of fellowships, actually many fellowships from the Wellcome Trust, Rockefeller Bellagio Center, and again Emory University. He has been the regional editor for India for the Lancet for 3 years, and he is an honorary fellow of the Indian Academy of Pediatrics. The fourth jury member amongst us is Dr. Priyanka. She has served in a key advisory role supporting national level policy formulation, strategic planning and program implementation to strengthen maternal health systems across the country. She has an active role in the development, review and documentation of multiple Government of India maternal health guidelines. She has also authored several peer-reviewed articles and has published in both national and international journals. The fifth jury member is not here. He is Ashish, who is a co-founder at TruthSignal.tech, which builds AI agents for hospitals. Previously, he has worked in incubation and VC roles at Social Alpha and Unlimited India, supporting deep tech healthcare companies, and he has been, kind enough to evaluate and sent us the scoring sheets. I think a few days back. So these scoring sheets are actually on the table. Please evaluate these, and we'll just collect it after our pitches. So I'll hand over to Utpal for our presentations, for our pitches. Thank you.
So, good afternoon to everyone. Thank you to members for coming up and accepting the invitations. So here we have five innovations, and before each innovation I will be setting the context. And we have asked them for a recorded video because we were anticipating little low internet back then here. So we will be playing the videos and I will be giving the context for that. So can we get the videos?
Do you know, every 3 seconds someone dies because of a delayed or misdiagnosis? That's millions of preventable lives lost each year. Hello everyone, I'm Pranay Agarwal, founder of Banking Plus. During my meeting when preparing for a hackathon, I came across some horrible stats from WHO that 2.6 billion deaths occur because of delayed and misdiagnosis, and more than 156 million people are getting harmed in some way or other. Cancers in India is one of the major contributors to these flawed diagnostics, as more than 20% of the cancer cases in India go misdiagnosed. Even I lost one of my family members because of the same issue. That's why this problem was too big for me to ignore. Therefore, I've started DiagnoPlus, an AI-powered SaaS platform which will assist doctors and radiologists to diagnose cancers and other diseases as well through imaging with an accurate and will also increase their efficiency by 10x. There are multiple types of cancers and diseases in the pipeline, including breast cancer, skin cancer, lung cancer, and many more. But as of now, we are very much focused on brain tumors. We have also filed the patent and PCT application of our proprietary tech architecture, and we have a fully functional prototype. I quickly take you through the working of our prototype. So this is a platform DiagnoPlus. So quickly take you to the user journey. So user will come to the portal and will choose the disease they want to diagnose for. Let's suppose we are doing it for brain tumors here. So for brain tumor, the user will fill the patient details like the patient name, age, and ID, and then the specific info. Just to mention, it is only for doctors and radiologists, not for patients. And once they fill the details, they provide the specific input. For brain tumors, we are using a soft copy. And once they fill the details, they provide the specific input. For brain tumors, we are using a soft copies of the MRI scans of the patient. And once we provide that, we can see a detailed medical report is coming out of it, which is not only a diagnosed tumor, but also the type of the tumor, which is glioma tumor in this case. And as we know, that the prediction holds no significance in the medical sector. That's why we came up with this approach where we are giving a detailed diagnosis instead of just a screening or a prediction. And this was a scan that was uploaded, and we have also the machine will also mark the affected areas in the report itself, so that the doctors can go through the report and can make their own decision if they really want to go with this report or not. And if there is something to be edited, they can edit the report itself, and then they can to the PPT. So we are thinking of you can see a detailed medical report is coming out of it, which is not only a diagnosed tumor but also the type of the tumor, which is glioma tumor in this case. And as we know that the prediction holds no significance in the medical sector, that's why we came up with this approach where we are giving a detailed diagnosis instead of just a screening or a prediction. And this was a scan that was uploaded, and we have also the machine will also mark the affected areas in the report itself so that the doctors can go through the report and can make their own decision if they really want to go with this report or not. And if there is something to be edited, they can edit the report itself and then they can uh, download the report and can directly send it for the treatment process. So in this way, we are not just relying on AI part, but we have kept the doctors equally involved.
can have children discharged.